Dobré ráno ještě jednou. Moje jméno je Ivona Remundová, jsem z Porodního domu čápa, který pro vás už rok plánuje tuto konferenci, takže jménem nás všech, které jsme se do toho pustili, tak bych vás tady chtěla dneska přivítat. Moc vám poděkovat za to, že jste přišli. My jsme se rozhodli před rokem tuto konferenci pořádat, protože se spousta z nás s porodem doma, v domácím prostředí zabývá, ať už ve svém vlastním životě nebo profesně. Ten hlavní nápad vznikl v hlavě Zuzany Štromerové, kterou spousta z vás znáte jako někoho, kdo se tady v České republice snaží už dlouhá léta mluvit o tom, proč porod doma má být jednou z normálních možností, jak porodit své dítě a nemá mu v tom být nějak bráněno. A my jsme se tuhle konferenci rozhodli uspořádat a prostě jsme se tak rozhodli, řekli jsme si, že za rok bude a že na ní seženeme nějaké granty, peníze, lidi, kdo nám s tím pomůžou, což se nestalo. A tak tady vidíte pobíhat spoustu lehce unavených, ale stále nadšených dobrovolnic, které pro vás tuto konferenci připravili. A mějte prosím s námi trochu trpělivost, protože opravdu tato konference vznikla téměř bez financí a na základě velké vášně spousty lidí, kteří se do toho chtěli pustit. Hlavním smyslem konference je opravdu se na porod v domácím prostředí podívat z toho odborného hlediska. Nebudeme se tady bavit tak, jak je v českém hlavně mediálním prostředí zvykem, o emocích, domněnkách, o tom, jak to bylo před 100 lety, 50 lety, jak by to mělo být teď, kdo je ten správný, kdo má na to správný názor. Prostě se budeme s špičkovými odbornicemi a odborníky, které se domácími porody tady u nás a ve světě zabývají, bavit o faktech, o tom, jak domácí porod například v zemích, kde kolem něj není taková hysterie, je součástí systému, co o něm vůbec víme, v kterých případech je to ta nejvhodnější možnost, v kterých případech je potřeba si dát pozor, jak může porod v domácím prostředí vypadat, jaké jsou možnosti. Jsou tady opravdu velmi zajímaví hosté a věřím, že tady všechny najdete tu přednášku nebo ten workshop, který vás bude zajímat a který vám přinese do života zajímavé informace. Protože už to tak bývá na všech konferencích, nějaké změny se objevily, některé z nich opravdu na poslední chvíli, takže prosím také nezlobte se na nás, když přijdete na workshop nebo přednášku a zjistíte, že je v programu trochu změna. Ty změny, které už teď určitě víme, je, že tady bohužel s námi nemohou být Jane Evans a Andrea Welling, které onemocněly, ale místo nich vždy v tom programu něco zajímavého najdete. Bude to například workshop Johanky Kubaňové o využití placenty, anebo workshop o násilí v porodnicích a o tom, jak by se situace na tomto poli mohla zlepšit. Další technická informace je, prosím, když se rozhodnete jít na nějaký workshop, u toho hlavního stolu, kde jste se všichni registrovali, se do něj zapište. A pokud byste se chtěli zúčastnit večírku, který teda je potřeba tam uhradit nějaké vstupné, stravné, pitné, tak se nám taky prosím nahlaste u toho hlavního stolu a to co nejdříve, nejlépe třeba do tady té první přestávky, my pak musíme nahlásit, kolik nás bude. Tak, ještě bych vás chtěla srdečně pozvat na modlitbu teze, která se odehraje v 6 a v 7 večer. To všechno najdete v programu. A teď už bych ráda přivítala naše vzácné hostky. Bohužel Jane Evans, která měla teda být v tomhle prvním setu, tak tady není. ale všechno zlé k něčemu dobré. Říkám si, budeme mít víc času na ta témata, která nás čekají. Takže bych tady chtěla přivítat a moc poděkovat za to, že přijeli dvěma dámám, Eva-Maria Müller-Markfort a Lucia Rocca. A předávám jim slovo. Děkuju.
Good morning to everybody. I'm really delighted to be here. It's my first time in Prague and I'm really so happy to be in this beautiful city. What I'm going to talk to you about today is about waterbirth in the context of normal birth. And I've been told we have a little bit of extra time, so we can take it a little bit slowly. And I hope you have lots of questions. I think probably we'll do the questions at the end. So in England, for quite a few years, probably since at least the early 2000s, we started discussing a lot about normal birth, what normal birth is, what is not. And eventually in 2007, the Maternity Care Working Party, which was like a consensus committee, which included Royal College of Midwives, Royal College of Obstetricians, and the National Childbirth Trust. They've met to try to reach an agreement about how we could actually define normal birth. And you may agree or not with the definition I'm going to show you in a minute. And in fact, we very much think is a definition in progress. And as you will see, is a definition normal birth here is defined with what is not happening rather than what should be happening to do with labor. I just show you the elements. So a normal birth is without an induction of labor, without epidural or spinal analgesia, without general anesthetic, forceps or ventouse, cesarean section. So as you can see, it's a very cold, narrow definition, but it's quite pragmatic because it helps us at level of all the hospitals and all the out-of-hospital birth to try to measure the birth which don't have all these interventions. And of course, from many of us, we think that in fact we should also certainly define normal birth to do with what is supposed to be happening with the support of women, continuity of care, etc. But it's a very pragmatic definition and in fact helps. And I'll show you a little bit later in a study conducted in 2011 called Birthplace Study, which you may have heard of, the rates of normal birth depending on the place where the women choose to give birth. And these were only low-risk women, so they could actually give birth in any setting they wanted. How the normal birth rates really differ a lot depending on where the women gave birth. So we'll go back to that in a minute. Oh, sorry, episiotomy as well. So why does normal birth matter? So we normally say that maternity services want to provide a care which is safe and high quality. So normal birth, by reducing morbidity, reducing costs and increasing users' experiences, can very well be used as a measure for good quality care. And in fact, the National Childbirth Trust in England, which is a charity made predominantly of parents, is lobbying a lot for using normal birth rates as a measure of quality. Now, when we actually asked women, what is it that helps you in labor, what they tell us is that one of the first elements of help is support. So having birth supporters, but also having one-to-one care by a midwife who actually is supportive. Understanding the process of labor, so this is particularly important regarding antenatal education. An environment which is home-like and makes them feel relaxed. Low lights, adequate temperature, so not too hot and not too cold, relaxing music, being able to move around in labor, and this is throughout labor, so early part of labor, whole process, when a woman is pushing, use of the pool, which is what we are going to focus on more in a minute, massage, breathing voice, and alternative therapies including aromatherapy. So this is based on a survey on about 600 women who, again, were low risk and gave birth in different settings. So, what happened, sorry, moving from here, all these elements which women suggested until, let's say, fairly recently, they were not supported by official evidence. So from the midwife's point of view, it was always quite difficult to be able to provide and support women through, providing all these elements, especially in hospital settings. Now finally, and thanks also to many midwives who have started becoming really academically developed and have been involved in big research studies, we started having some good research, which finally is proving that most of these elements are actually true and they are in fact supported by research. So I've summarized here for you some of the Cochrane Reviews which are relevant to normal birth. And these include, and it's not comprehensive, but it's just to give you an idea of how finally we are moving in the right direction. So continuous support in labor for women is actually one of the strongest systematic reviews we have in childbirth, and it has shown how important it is. Mobilization during first and second stage, and immersion in water. And I put epidural there towards the end because actually we know that when women have epidural, they have much more risk of having interventions. And we'll have a quick look through each one of them. So continuous support for women during childbirth, what this systematic review looked at was both support by birth supporter, but also by caregivers. And the amazing thing from my point of view here is that they didn't even specifically looked at systems in which there was a known midwife to the woman throughout pregnancy, so didn't particularly focus on case loading or systems in which the woman knows her midwife. This is support by a staff in hospital, and most likely this would be a midwife. And still, it proven to be crucial in order to decrease the need for pharmacological pain relief, decrease the rates of instrumental birth, and also has been proven to decrease rates of cesarean sections. So this should really be the base of how we set up our care. And of course, this especially is important for hospital care. Normally for home birth, we don't really have that problem. Again, we have evidence finally supporting the fact that women should be allowed to move around in labor. And this is for first stage of labor, shown to make labor shorter and also less need for pain relief. And also for second stage, what the review said is that the research was not really strong. However, it showed that women moving and choosing position for second stage, there was some evidence of reduction of instrumental birth. Now, when we look specifically about immersion in water, what the reviews showed is that particularly it reduces the need for pharmacological pain relief. And we know really water birth does much more than that. But at the moment, we have been able, especially in England, to use this Cochrane Review to start, using it as a tool to go really, especially for hospitals, to go around and say, look, there is evidence it reduces pharmacological pain relief, so every labor ward should have pools available. So what are the benefits of using a pool for the mother? So we know, first of all women say that when they use the birthing pool, they feel more relaxed, they feel more private, they feel more in control, they feel the pool is their environment, their space, so they feel protected. As a consequence of all of this, it would reduce stress hormones, so adrenaline and noradrenaline. We know it reduces the need for pharmacological pain relief, and we'll see in a minute, from hormones' point of view, how can we explain all of this. We know that helps labor becoming quicker. So there was in fact a study which was quite interesting, which showed women who were considered to have slow labor, half of them were offered the use of the pool, and the other half augmentation with oxytocin. And guess which group did better in terms of quicker labor? The women who used the pool had quicker labor than the women with oxytocin.
By how much? By how much? How much quicker? 10 minutes?
I don't know the time, but probably hours. But
I
we
doubt
can.
it.
Say again?
I would like to know that.
Okay,
I think
I
you'll
can give
find
you-
it was probably 10, 15 minutes.
The importance we think
So-
is,
Right, I mean,
Yeah.
that is important.
Can we please leave the questions for afterwards? Thank you.
I can give you the reference for the study, and as all studies, you know, it's just really the tip of the iceberg.
Great.
As I've been saying, all these Cochrane Reviews, when you really dig into them, they are really, you know, they are based on sometimes very small studies, but what the message I'm trying to bring is that we have all our experience as midwives and the practice we have, and sometimes we found it difficult to confront, especially with hospitals, and that's why we need this part, because we can use that as well as our knowledge, and we know there is much more to it than the Cochrane Review. But it's important to have that side as well. But I'll pass you the study later. Also, women, when they are in the pool, automatically they tend to move around, and especially they go naturally in all fours position on hands and knees, which is a position which really, really helps, especially during the second stage, helps avoiding baby moving in the wrong position or back to back. So really helps, because of the buoyancy of the water, the mother can really move around and just kind of roll backwards and forwards. And because of that reason, the woman will use less energy to move around, because of course in the water there is less weight. For women who have a little bit of on the high blood pressure side, the water has an effect of reducing the blood pressure, so sometimes that can be quite handy. And this is at the end, but really should be guiding everything else. We know women who use birthing pool for part of labor or all the labor, they have much better satisfaction with their experience of birth. So this is actually one of my best friends who organized a home birth in a small village in Italy. And as you can see, that is an English blow-up pool, which came from London directly. And she's the only woman in that village who had a home birth, water birth in the last 60 years. And in fact, when she went to register the birth, they were not believing she could actually have a home birth. So it took a bit of convincing. No, my baby actually was born at home. And the reason why I wanted to talk to you about water birth in the context of everything else is because water birth is not just a tool you use by itself, but you use it as part of many different things. So having a relaxing environment, organizing a room with different areas in which the woman can move around depending on how the labor is going. So my friend Emilia, she had a very quick labor. It was her first baby, but she really had a very quick labor. So what she was doing, she was trying really to be quite flat down, so she would not increase contractions even further. So we use quite a lot of positions, and using gravity, so the more upright you are, the more you help speeding up labor. the more you stay kind of upright, but never on your back, because that, of course, is not helpful. So she found this position very useful, but also she felt it could control the contractions a little bit better, because they were almost getting unbearable because they were really, really close together. She practiced yoga with me since we were really young, for many, many years. So she was doing mantras all the way throughout labor. And that in combination with the use of the pool really helped a lot. And this is my favorite picture, because you can see this was at the peak of a contraction, but she was so concentrated that you could almost, you wouldn't really know she was having a contraction. So if we look at the powerful effect of water, we can briefly divide in 3 sections if we want to divide it. So you have the physiological effect, and we know the warm water plus, so the effect of the water and the temperature has a physiological effect on the mother. From psychological point of view, we already mentioned about the fact that water relaxes the mother. And we can also consider there is a spiritual side to it, because the woman in the pool, she gets in a very deep relaxation, and she gets almost in a kind of different state of consciousness, which really helps her concentrating in her labor and really letting it go. So if we look from hormones point of view, so what happens during first and third stage of labor? So if our stress hormones are low, so that's when a woman is relaxed, her stress hormones are low, her endorphins will be high, and her oxytocin will be high. So this is the ideal situation we want to create for our women. So that's why the environment, any stimuli that makes the woman produce adrenaline needs to be kept under control. So of course there is nothing worse for a woman in labor to walk in a labor ward in a hospital where she has strange people around, machines, horrible hospital smell. So all of that will make her stressed out, produce adrenaline, which automatically will make her feel more pain with the contractions and will slow labor down. So that's why we tend to say that if we train in hospitals, it's very unlikely we can witness a real physiological birth, because automatically when women come in hospital, the physiology is altered. Now, for what regards second stage, the situation is a little bit different. And midwives are very familiar with this, because when we move into transition and second stage, the woman changes behavior. She starts feeling hot, agitated, maybe turns a little bit more on the aggressive side. And that's because she starts producing catecholamines, which in fact, for the second stage, are good. And that's what the woman needs in order to be able to push. And that will go together with high endorphins and high oxytocin. So quite different, but I found this little scheme very useful when I was much younger to guide my practice, because I was always thinking hormones. And if I saw a woman in labor, her labor was not progressing the way I wanted, I was trying to understand, if she's in first stage, what is it that can be altering her hormones? So I would look at the environment, I would look, is she eating, drinking, is she relaxed, is there anything that make her feel uncomfortable? And sometimes actually maybe she's worried about something, or sometimes birth supporters can be anxious and influence mom that way. So sometimes in birth centers we have maybe 5, 6 birth supporters. And in occasions, maybe the mother's mom is very, very anxious, because of course she feels really protective for her daughter. So sometimes we kind of say, look, let's go outside and have a cup of tea together. And suddenly, as soon as the person passing adrenaline to the mom goes out of the room, the labor goes back to normal. Yeah? Because adrenaline also is contagious. So it's not just an anxious birth supporter, but if you have an anxious midwife, in the room, she will have an effect on the labor. So that's why it's so important that we feel relaxed when we look after women in labor, because the adrenaline is really contagious. So I mentioned earlier I was going to show you some numbers to do with normal birth. So this is an extract from Birthplace Study, which is a study conducted in England in 2011. And if you look, this is rates of normal birth, applying, you remember the little list of things which should not happen to consider it a normal birth. And really, the farthest you go from the hospital, so the lowest rate of normal birth is in hospital, then AMU is alongside midwifery unit, is a birth center within hospital setting. And then you have freestanding midwifery unit, which is birth centers outside in the community, so out of hospital birth. And then the highest of all is home birth in terms of achieving normal birth rates. So if I have to say, nowadays, is water birth standard practice in the UK? And we have, unfortunately, to say, despite all the work we've done until now, it's not the norm yet. We are working on it. We are really pushing for having more home birth and birth centers. But especially in the hospital setting, we still have many midwives who don't feel confident, they feel quite okay in telling you, I don't do water birth. And my husband is an obstetrician, and if he went around saying, I don't do forceps, he would not be allowed to say that. But why is a midwife allowed to say, I don't do water birth? So that's what we try to work on. It's not just the skills, how you actually do it, is working on why it's important to do it. Why, as a midwife, you want to do water birth as well, because it gives you back something as well. So we try to work with loads of midwives, especially in hospitals, to teach them, but also to be there present, to help them assisting in water birth, so they feel safer in doing it. So maybe 2-3 times with support, and then hopefully they feel safe enough to keep going by themselves. Oh, I'm finished. So these are some very nice pictures from home birth, water birth. And I'm very happy if you have more questions for me. Thank you. Oh, and sorry, by the way, I was going to forget. I kept it more from the kind of evidence and general practice point of view, because we have later a workshop for who is interested. We have then space to actually try to go more through the practical things together. So whoever is interested, I think is at 11, if I'm correct. We have 1.5 hours to work just on the practical side for whoever is interested. In room 6. Thank you.
Well, thank you very much. Yes, you put it on. And you can here put these on.
Oh.
Yes, Ivona brought them in. And it's all set, she says, and you only push this up.
Okay, sure.
You're
Too
right.
much.
Okay, so, yes, thank you very much for this very interesting presentation, Lucia. One point I would like to make to your the psychological effect of water birth. If the woman is in a very deep regression during her birthing process, and she is in water, she is again back to that very, very early stage when she was a baby in her mother's womb, in the water, where she was in safety, where she could abandon herself, where she didn't have to do anything and think, she was just there and things happened. So actually she will be on the same level than the baby she's carrying, and it may help the two on the same level to come to some kind of understanding and like this support the birth process.
Absolutely. I'll bring the microphone. If there's any questions, I'll bring the microphone to you. Any questions?
Yes, questions, please. The lady has gone who was here before. It's always the first one must dare to put up the finger. You can do it in there is one over there.
Are there any specific conditions for the pool?
I don't need that, sorry.
Are there any specific conditions that the pool needs to meet, like the temperature of the water, type of the water, pH, and who sets up the pool and the environment?
Yes, thank you. So until now, until a few years ago, we were really, really careful that the temperature should be specifically 37.5, or we would be quite kind of scared about the environment. Let's say with more practice of water birth, we have relaxed a little bit. So there are some general criteria for which woman can use the pool, or we recommend a woman to use the pool. So for instance, if she has prolonged rupture of membranes, or she has temperature, or any sign of infection. So let's say if the woman is unwell from any point of view, we would not recommend the use of the pool. In terms of temperature, really, what we need to focus more on, and more than anything else, is for the water not to be too hot. Because if the water is too hot, let's say if the water is 38 or 39 degrees, inside the baby will be probably 1 degree higher. So that's really the only danger of water birth, to have the pool too hot. So if it's on the cooler side, better. And normally a pool is quite big, so it loses temperature quite quickly. So we have during labor to top up with extra water. We normally have a floating, like a baby thermometer in the pool. And as by guidelines, what we need to do different in terms of practice is we check the water temperature every hour, and we document it. We check maternal temperature and heart rate hourly as well. And in general, we say we want to make sure the mother is hydrated, so she drinks plenty, because even if she's underwater, she sweats, so she loses fluids. And she keeps energy high, so she eats a little bit every now and then to keep her energy high. So in terms of other guidance, let's say, as I said, there are specific cases. If there is a meconium stain like where we would not recommend the use of the pool. There is nowadays, because we are getting more confident with the use of the pool, we are extending the guidelines a little bit. So for instance, women who had a previous cesarean section, in many birth centers within hospitals, some of them accept mums to have a water birth there. Some with the underwater monitoring, some without. Normally, in birth centers in England, we don't have monitoring. So in some birth centers, if a woman who had previous cesarean, if she wants to use the pool, she will have to opt out of using the monitor. So we have a discussion about risks and benefits, and the woman says, okay, I understand the risk benefits. For me, the benefit of using the pool is so high that I want to rather opt not to have the monitoring. So that's the type of discussion. And like that for anything else. So if a woman has prolonged rupture of membranes, but she has no signs of infection, she could, if she wanted, still discuss risks and benefits and opt for using the water. But again, she would have to probably opt out from continuous monitoring. In other cases, if there is a real problem, so if we actually do have a sign of infection, in that case, we would feel a little bit stronger. So in that case, we would strongly recommend not to use the pool, because of course, if there is an infection going on, the heat of the water could make things a little bit worse for the baby. Yeah. So really, I would say to do with the pool, the main thing, my advice when I teach midwives is if we want to look at the dangers, is two things. One, the water not too hot, and when baby's born, normally the mom takes her own baby just to have a quick look at how long the cord is, because there is always a risk of cord snapping, the cord breaking. And because you are very often in a dark room with low lights, you can miss that. And again, you know, it's not that we need to intervene. We do that in a way the mom doesn't even see that we are checking without disturbing. But if there is any cord snapping, that can really have a very, very, you know, is a big risk for the baby. The baby, we had only, I think, one case in our birth center in 7 years. Sorry. The midwife thought was the blood coming from the placenta, was actually blood coming from the baby. And the baby finished in intensive care for quite a few weeks. But again, it's one case over, we had more than 5,000 births. Sorry. I hope I answered your question.
Yes, thank you. I have one more question.
Sure.
Two more.
If I survive. Yes.
This one is quick. At what stages of labor the woman is in the pool? Is it first, second, and third? Or?
Okay. So, again, that's something we've changed quite a lot since we started. When we first started assisting Waterbirth, we were told the woman needs to get in the pool when the labor is really advanced. However, with practicing a lot, we have realized every woman is different. So some women may find advantageous to use the pool in very early labor. Because also the concept is that a woman doesn't get in the pool and just stays there. The pool is part of everything else. So the woman gets in, stays for an hour, so relaxes, then gets out, you know, to get some fresh air, moves about, go and have a pee, and everything else. So it can very well be that she might get in early labor. It can be that the contraction become even stronger, in which case she may prefer to stay in the pool. In case contractions slow down, she may at some point want to come out and walk about a little bit. But it's really very much to do with the woman's choice, not our. From our point of view, really, we would observe how the labor progresses, and then we can give advice and say, look, you've been pushing for 2 hours in a pool, maybe it's a good idea to get a little bit out, to push a little bit outside and see how that goes. But eventually is what the woman prefers to do.
Okay, thanks.
You're welcome.
And, one more question.
Sure.
When the baby comes out, how long does the baby stay under the water, or you're supposed to raise the...
So when the baby comes out, do we have a connection there?
That I don't know.
Oh, we'll ask in a minute. So when the baby comes out, normally the head is delivered, and depending how often the contraction come, you can even have the head delivered up to here underwater, and you can have the baby looking around and doing this. And that's what sometimes is scary if we are not used to. Many of us, we learn almost by ourselves. So we had to kind of wait and watch a little bit, and then we learned that that's totally normal. And then most likely with the following contraction, the baby would deliver himself or herself. So we usually say it's a hands-off approach. And normally, if the contraction after the baby has not come out, we would consider whether to ask the woman to stand up. And in that case, she would give birth standing with one leg on one side of the pool. It really depends how often the contractions are coming. You want to look at the whole picture. But then baby is born in water, and it again depends. The woman can pick up the baby, and it can stay underwater for a tiny bit. So if, for instance, you note there is cord around the neck, what you want to do is to keep baby underwater, undo the cord, and then you get the baby out of the water. So it's not rushed. But again, as with practice, at the beginning you will be a little bit more anxious about doing things quickly, and then you realize that actually, you just try to think the baby is in water inside mom's tummy, so it goes from water to water, which is similar temperature as the mother. So once you become a little more aware of this and you really see in practice, you can really enjoy that part, which is beautiful, because the baby is born, if you don't even touch the baby's kind of swim. It's really beautiful, and it's very nice. And again, you'll have moms who are completely there and they want to take their babies. You have other moms who are quite away, in which case either you or the birth supporter will catch the baby. Yeah, there is no rule about that.
Thank you very much.
No worries.
So, some more questions? Yes, please, over there. And be short, if possible, so that we are in time for the coffee break in half an hour.
Hello. The question was, after the child is delivered in water, is the placenta as well going to be delivered in the same way, or it's safer to take the mother out?
Okay. Now, there is a topic which is still under discussion, and most of our guidelines in England would say that the placenta should be delivered outside water. However, as we became more confident with our practice, if a woman is sitting in the pool, relaxing, and the placenta comes out quickly, we are not rushing to get the mum out. So it's really, from our point of view, a matter of the clinical picture and the situation of mum, how mum feels. If it's been a very long labor and the mother is very tired, then you can ask her. And the placenta discussion is linked to other things, such as when you cut the cord and how do you give birth to the placenta, physiological third stage or active management. So very often when you do water birth, mostly mums opt for physiological, so no drugs whatsoever. Mum will use her own oxytocin and she will push the placenta out. Nowadays, you're aware, we always recommend delayed cord clamping, so not clamping the cord at birth, waiting at least minimum a minute, but normally it's more than that. So that's all linked, because baby's born, you don't want to disturb mum, baby goes on chest, skin to skin, cord is left intact. The main focus there is on bonding, do not disturb mum and baby. So the midwife there, her job is normally to take pictures. And the reason why we introduced this is because then the midwife doesn't get stressed thinking about the placenta. You remember what we said earlier, stress is very contagious. So if you remember the little scheme of the hormones, you want low catecholamines in first and third stage. So for first stage, I think we know a little bit better now, but the one that is completely underestimated is third stage. So if I remember how we assisted the third stage in hospital, it completely shocks me now. Bright lights, people coming and going, dress the baby, clean the baby, and our practice at home and in birth center is completely different. It's about respecting bonding, do not disturb. And in that picture, there is a decision about third stage. So normally, there is a discussion before birth. Then again, after we ask, what would you like to do? We follow very much what mum wants. In terms of practicality, there are two things to take into consideration. One, if the mother is bleeding excessively, it can be difficult to see that with a full pool because the blood gets mixed with water. So you need to have enough experience to understand, depending on how opaque the water is, and you need experience for that. That's why many midwives advise the woman to leave the pool. Second, sometimes after the delivery of the placenta, the mother can feel a little bit fainty, and if she's in the pool with the baby attached at the cord, just logistically can be difficult. So it's always about protecting the bonding, but also considering everything else that is going on. How the mom looks like, is she looking strong and able to leave the pool? Because if you leave the pool with the baby attached to the placenta, also leaving the pool, you need to make sure that you don't pull the cord. So a few practical things to consider, but it's a decision that normally is made between the midwife and mom and the birth supporters.
Can you maybe stop here, because you've got a workshop this afternoon.
Yes.
There's 1.5 hours this afternoon.
Absolutely.
You can still ask questions, and I'm sure there are many, many more details you can...
So all the details, yes, the plan is to discuss that in the workshop a little bit more at length.
Good. Yes, is that all right with you? Thank you
Yes,
very
thank you
much.
very much.
Yeah, thank you very much, Lucia, because this is
You're
that was very interesting. One thing I sort of raised my eyes. You said you wait 2 minutes before clamping the cord. I thought the cord was going to be clamped when the pulsing, thank you, has stopped.
Normally, the 1 minute comes from guidelines, but in our practice normally we don't even count the time. I mean, it's not something that concerns us. You just don't clamp the cord, full stop.
Okay.
And then
now I feel better.
Yeah.
I feel better. Thank you very much.
thank you.
So we want to go to coffee early. Now I'm the next one, so I had to keep the time as well to finish my paper. There is an exact translation of this with the ladies, so I'm going to read it through, and you get the exact translation from the two ladies behind the glass window there. So, thank God I'm a home birth midwife and I don't have to worry about all these things, whether in or out of the bath or cord clamping or not. We do as the mother likes and as I feel it's okay now. And a good home birth will know when it's okay to do this or not to the other. So from the very practical side of accompany a woman, I'm going to the pregnancy, because as everything else, prevention is most important if we want a good result. Every gardener knows that he has to make a good earth, fertilize it, and so on, and then he puts his little seeds in, and then he goes round and he sees how they grow, and he's pleased. So we must make a good grounding and a good preparation if we want a good birth and a healthy baby afterwards, and a good relation between mother and child. So for many years now, my main aim has been to see to it that the mother and the baby have a good contact during the pregnancy. That's the begin with and end all of a good pregnancy, good birth, and they have to live a very, very long life afterwards, as you know, mums and her children. And it is good if the starting is good. So, mothers have always had, is it all right like this here? Mothers have always had ways of communication with their unborn child. Be it by caressing the beautifully rounded belly, you know that all, or by pushing gently baby's feet away from under a rib, saying aloud, "Oh, please don't push your feet so far, it hurts." Or by speaking with the baby mute, with their inside voice, being sure that the baby will hear what she says. Or by daydreaming and seeing pictures of times yet to come, with a wonderful and beautiful child in her arms, cuddling and kissing it. But there is still another way of communication on a very, very deep level of the subconscious. On that level, it is possible, too, for the baby to answer to its mother. This is not by words, of course, but there is an exchange of information between mother and child by messages and pictures, which the mother is capable of transforming and expressing in words. For instance, I can ask the mother to ask the baby, with her inner voice, how it feels. So the mother conveys my question to the baby. There's a moment of silence. Message comes up. And then the mother will say to me, the baby says, "It is feeling well right now." Or the baby says, "It is getting tight in here." Or the baby says, "I'm looking forward to my big brother, to play with him, but I don't like when he makes so much noise," and so on. that teaches us that babies know everything about what's going on outside, so we better be careful. Sometimes the path to the baby is bad, and then it takes a different method called guided affective imagery to take away the stumbling stones between mother and baby. But this will not be discussed in this paper. Now I will give you some examples of my experiences in my daily work. I must again point to the fact that I have been working with this method for the last 20 years almost. It's 18 years maybe. And I have learned to trust whatever the mother tells me about the baby. Now I concentrate long stories, and a session may take up to 1 hour, 3/4 of an hour, 1 hour. I make it very short. After having had a few meetings, the baby is already waiting for the mother. It knows in advance that she's coming to meet it in this special way. The mother says she sees the upper part of the baby. She strokes gently its shoulder and tells me that there's some kind of cream on the skin. You all know what it is, it's the vernix. Mothers don't know that there is vernix on the shoulders of a newborn baby, but she can feel it. The baby looks at mother, and suddenly she takes the baby and they begin to dance in the womb, the two of them. And when they are both tired, they cuddle together. Suddenly the mother says, "The baby wants me to leave. It is very tired now." She says goodbye to the baby and goes. And she learns by this way to respect baby's wishes, which is good for later times. So the second story told in short. In deep trance, the mother suddenly giggles. I wonder what is happening inside her. She explains. The baby just said, if I should ever eat again that same stuff like yesterday, it will really be upset. I ask the mother, what have you eaten yesterday? And she says, I had suddenly such a yearning for a big plate of French fries with a big heap of mayonnaise and ketchup, and I cleared the plate in no time. And this the baby didn't feel funny about. Now, of course, I am interested as a midwife. How does the baby know that mother has eaten French fries with mayonnaise and ketchup? So, when do we have an opportunity to get some information from the baby itself, from first hand, so to say? So I asked her, would she ask the baby how it knew what the mother had eaten? And the baby explained that after the meal, the blood had been thicker as usual, unpleasant, not so gently pulsating through baby's body as usual. Cholesterol is waving at the end of the road. The mother promised to wait until after the birth of the baby to do that again, and the baby was satisfied. And a third story. A colleague phoned in the morning. She had spent the night with the family. The first twin was born, but after that the contractions had stopped completely. Would I come and stay in the house? She wanted to go home and have a shower and see to her postnatal visits. So I cancelled my morning visits. I went there, and we agreed that I would call her as soon as the contractions would start again. It was a nice summer day. Nothing happened all day. We were sitting out in the garden. In the afternoon, I was wondering why the second baby would not come. In the meantime, the first baby was already 12 or so hours old. So I wondered why the second baby would not come. The contractions had stopped, as I had learned by then that there is always a good reason for everything that happens. So I suggested to the mother that we could speak to the baby and ask what is the matter, why it is not coming. The mother had never heard of this method, but she agreed, saying, well, let's try that, maybe it may help. So I explained to her how it works. So the mother, who did not know the method, agreed. Very quickly, she was in contact with the baby. I made her ask, always in her own voice, in her own words, how the baby feels and why it won't come. His little brother is doing fine out here, and we are all waiting now for the second baby. Why did it stop the contractions? Then, of course, as usual, silence. And then after a moment the mother said, the baby said, it is afraid. They had been doing so well, the baby said, both of them together, the twins, all the time. But then, of a sudden, his brother had disappeared, and now it is afraid of what might happen to him. We discussed to and fro about what to do so that the baby would come despite its fears. In the end, it was agreed between the mother and the baby and me that the baby would take more time but would decide by itself when the right moment would come. And it did not want any help, no drugs, no nothing. It would come under its own steam, so to say. So we waited. We waited, and we were sitting in the garden and waited. In the evening, the other two midwives came back for the night, those who had been there the night before. So I went home at about 8 o'clock, and by 10 o'clock, when the big sisters of this little baby had gone to sleep, and there was at last peace and quiet in the house, the contractions started again, and 20 minutes later, the second little boy was born in good health. 2 days after his sibling, from the date, by the date. As you can imagine, it takes time to get this information, sometimes up to 1 hour or so. But midwives have learned to be patient. The reward always comes in the end, as you know. So, there are sad moments as well, of course. A mother cried a lot during the session. She had separated from the baby's father. But suddenly the baby told her that she should not worry so much, and that the baby knew that the anger and sadness had nothing to do with the baby. This made a big impact on the mother, now as she had feared that the baby might be caught in the middle of the struggle of separation and suffer from it. So I will stop here, and you can ask some questions, and there will be a workshop in the afternoon for those who want to know more. So I must organize myself now. Questions, please, for those who want to ask something. Big silence. Yes, please.
Thank you. That was really interesting, quite fascinating. Are you saying that you are actually practicing hypnotherapy?
It is a little bit in that way, hypnotherapy. It is a little bit between hypnotherapy, between deep relaxation, but it does not need hypnosis to get women into a anybody into a relaxed state. It's just to take you off a little bit out of your head, you know. And women know what goes on as well. They are in this double condition. They hear, they speak with the baby, they hear, and they hear when there is a noise or something in the house that worries them. It is very interesting because in the beginning too I thought, oh, it must be in a very quiet room, that they are not distracted, they are not being taken back into the, into the cortex, back into the head. But and then the bonding analysis, which is a system by its own, they say, for instance, that while the mother is lying, she should not have her hands on the belly, because if she's on this deep level of relaxation and she has her hands on the belly and the baby moves, that will distract her from where she is right now, maybe dancing in her room, as I told earlier. But this is not so. I must say the bonding analysis has been developed by men, psychoanalysts, and they have a different approach, as we all know. They can't help it. They never had a baby in their womb, so they can't know. So they are they can sort of travel very quickly from one level to the other. It is not hypnosis, but it's a little bit, sometimes they go very deep, yes. Yes, please.
Do you,
excuse me, can you please wait for the microphone because they can't translate your question.
Oh, I'm sorry. Yes. That is very kind of you. Thank you.
can you, is it on?
Yes.
What I don't understand about what you're saying is, are you actually saying that you believe or that the baby is intellectualizing, or are you saying that it's the woman's deep emotional beliefs about what the baby is saying?
No, I'm pretty sure that it's not something that the mother makes up. I'm pretty sure of that. And not what she believes, because sometimes she says things which are not so pleasant for her. There have been, of course, very, very highly emotional sessions as well, and arguments with between mother and baby, when the baby says, I don't think that you really want me. A mother who went over the date and we were wondering why, and the baby said, well, I think that she repeated what the baby said. She said, the baby said, I think that my mother only wanted to become pregnant, but I don't think whether she really wants me. Now that is something that a mother doesn't say so easily. And whether this is a moment of truth where her own deep guilt feelings maybe come up to the end, we will never be able to explain really. But I've been speaking to babies now for many years, and I am sure, and there is even a scientific explanation how it works. I can, if you are interested, give it to you or anyone else, you just mail to me. How this works, how this communication is on a very deep, very, very deep level between the mother and the baby inside the mother's organism. I cannot explain it, I understand it, it's very difficult, I cannot really explain it, but I can send it to those who are interested in. I really rely very much on the messages that come back from the baby. If the baby says, oh, it's so nice when Daddy puts his hand on your belly, I can feel Daddy's hand when he massages me through your body. Things like that. And sometimes the father comes as well, not all, but some do. For men this is of course a little bit of witchcraft, I know, they don't like that too much, but some husbands come and then they are bewildered and they are melting away. Even when we never mention the daddy, suddenly the baby will say, I know that Daddy is there, I'm happy that Daddy is there as well. And then the father, of course, he sort of collapses almost. Of course, one could say the mother sends the messages. In the end, you can, if you want to tear things apart and explain everything, you can explain even God and the rest of the world. But I feel very, very confident. But still, I have my brain. Baby can say, I'm fine. If mother has 40 degrees fever and an infection, well, I would not say, oh, I do nothing, because the baby says it's fine. You understand what I mean? But it's part of my assessment of a situation. Yes, please. There's someone behind there for the micro.
Já bych se chtěla zeptat, jestli je potřeba, aby ta žena měla nějakou už zkušenost s nějakými relaxačními technikami, nebo můžete pracovat s kýmkoliv, kdo se třeba s něčím takovým setkal poprvé. A jestli třeba vnímáte, že je jako vidět rozdíl u někoho, kdo to slyší poprvé a kdo už v tom má nějaké zkušenosti. A jestli jste také třeba došla k nějakému momentu, kdy to nikam nevedlo, kdy prostě ta maminka neslyšela nic a nedovedla interpretovat vůbec nic.
Good. If I forget one of the questions, you remind me. You can do it with anyone, and in the workshop this afternoon we'll try out and see how many of those who come will sort of get straight away into this way of dozing away. It is a state just like the moment before we go to sleep. You know, you're almost off. You're not quite yet off, but just the moment before. Sometimes they will fall asleep. If they are tired, they had hard days, one of the siblings, bigger children, has been sick, they haven't slept, they will just sleep. And then, of course, I just let them sleep because it's the best for them at that moment. And they will wake up after 10-15 minutes. Then I have forgotten the questions now. Can somebody...
Let me remind you again. If you can see the difference, jestli vidíte rozdíl, když je ta žena sorry, I can speak English. If you can see the difference, if the woman has some experiences.
Okay, please stay.
No,
okay. No, it's okay. I answer one by one. No, there's none at all. As I explained with the second twin, she hadn't even heard about it. She didn't know at all what I was going to do with her.
A jestli se stává, že se nenapojí ta maminka s tím děťátkem, že neslyší vůbec nic a co, když tak jako v tu chvíli pro ní můžete udělat?
Yeah. This happens quite often, and it is very, very rare that a woman has at the first time a direct contact with the baby, because we all have in our subconscious all sorts of problems and things and traumas and what has happened to us over the years, and even some people say we get from our forebears problems which we carry around like in a big rucksack and full of stones. So if there are major problems, then we must sort of clear the path to the baby, and that is with a different method. That is not so difficult either. But then already I know that there are a few problems that have to be cleared before we start on the proper bonding, mother-child connection bonding process. And what I like about this system is that the problems she has, which can be cleared, once they are gone for good. They are gone for always. So midwives, who are and should be the first caregivers for pregnant women, have a big chance really to help women to get rid of some of their problems from the past, including birth experiences which were hurtful, or lost babies, or sometimes they hadn't time to say goodbye to the last baby who went at 2, 3, 4 months. And there's something that stays in the womb about these dead babies, the babies who died, and that sometimes prevents her to get into the contact with the now living baby. And if she could say goodbye to the other baby, everything is good, and by the next time, suddenly she will say, "Oh, I can see the baby, there it is lying there and sleeping." So we can do so much to really clear the path to a better life for the woman, for the future, to a better contact, bonding, and all between her and her baby, better birth experience, and which is again important if the baby is supposed to be born at home. I'm an old home birth midwife, so I'm doing everything to clear the path on the psychological level to be sure that the birth process will go well. And breastfeeding is no problem afterwards. Women have no problem, no traumatizations. I go there postnatally, there's nothing to do anymore really. You go and you're happy with the mum and you have a cup of tea and you think love is wonderful, life is wonderful, love too of course, but life is wonderful as a midwife. And it has improved. It has changed my way of working, and it has changed my life too, because I'm so happy working this way, getting problems out of the way for her and the little child. Yes? The last one, and then we will be off for coffee.
Já jsem se chtěla zeptat, jestli umíte pomoci budoucí matce mluvit z duší dítěte. Aby vlastně to děťátko přišlo ještě vlastně jako kdyby s tím početím. Jestli i umíte pracovat s touto metodou nebo s tímto postupem. Děkuji.
I have done it once. I've done it twice. Once the mother has come, and this is a long time ago. She came a few times and then she moved away, but she was still in the sort of do I want or don't I want to be pregnant? So in fact she realized that although she wanted a child, but there were other parts in her which didn't want a baby. And the second one came twice, and that lady I remember well. And we even didn't do anything the second time. We had one session looking into the uterus, which she did straight away. And the second day she came because we had the appointment. She said, "I'm not doing anything right now. I realize that although I do wish a baby with my head, I have so many other things to clear before that. I will postpone my wish for becoming pregnant at any cost, sort of. But I have never had a woman who then got pregnant and had a good pregnancy and birth. But it should be possible. It should be possible. Try out. It really you can hardly do anything terribly wrong. Because the subconscious of the mother is very strong and will not go further, let you or the mother go further than it is good on that day. That is one thing I have learned too. One must not fear, if I say this, if it's not supposed to be, it won't be today. It will come back later, one day. So one can be confident about using this method. It's very good. So, coffee is calling, it's 1:05. Thank you very much for listening. I hope I triggered a little bit of an idea that we can be more than pulling babies out of women or things like that. And the workshop is this afternoon somewhere in 9, I think in room 9. Yes, room 9. Okay, now have a good coffee break. Time to talk.